okay, we have some good options up front, be it sequencing or using everything up front, but then there is still a small subset patient population that will progress through all this. Now we also have Liso-cel that's approved. Liso-cel is being used with other PTK inhibitors as well as a combination. John, as a community oncologist, CAR T in CLL, your thoughts here?
Yeah, I mean, so it's a welcome. I'm so glad it crossed the threshold of being an option for our patients. It's something that, if it works, can be potentially curative for some of the worst patients that we have, the ones that have broken through all of these top drugs that we use, and might actually have high curative potential in those patients that get that response. The unfortunate thing is that only about 20% of patients got that complete remission. It's only important to really look at the complete remission patients because everybody else will eventually progress within 1 to 2 years. Only about 20% of those patients got to that complete remission. So we need some work done in showing how to optimize and improve that. One way to do that is in combination with a BTK inhibitor. In this case, it was ibrutinib. Ibrutinib has some T cell effects and some immune modulation, which is the BTK wasn't on board for the CLL component. It was really on board to modify the T cell component and to improve that product. And we do see higher response rates. We do see higher CR rates. It pushed it up to about 40% of patients. I think more work needs to be done. It's a great option for patients who are breaking through some of these therapies, those with very high risk disease, because that was definitely represented in these studies, those with deletion 17p, complex karyotype, multiple prior lines of therapy, double exposed or double refractory to BTK and BCL2s. Where to place it in the setting of reversible BTK inhibitors, which has an indication in the same line of therapy after exposure to covalent and BCL2, remains a question and remains uncertain. Toxicities are very, very different. Pirtobrutinib and other reversible BTK inhibitors that are being developed in the space, Pirto being the only one FDA approved, is very easy to reach for. You can get a patient started within 3 to 7 days of writing a prescription and having it delivered. It shows remarkable efficacy. 80% of patients are responding in very high risk disease. That response in these patients in the fifth line setting essentially is limited. It's only about a year and a half to 2 years. Nonetheless, that is a way to get disease control. If you're starting on pirtobrutinib, I think most people would say that's kind of the first reach and go to in any of these progressing patients. That is somebody you need to then start talking to your colleagues in the community centers or to your BMT colleagues doing CAR T, because that's a patient that will potentially and likely need CAR T cell therapy in the very near future. And the logistics there can be complicated, need some lead time, need to be established with those practitioners. And so when the time to strike is right, they can move quickly and get the patient collected and treated appropriately.
Well, exciting times indeed. And I got it at our ASH satellite event. We moderated a session, and the recurrent theme was use of bispecific antibodies and CAR T in heme malignancies, where again, the tie in for community oncologists to reach out to tertiary and quaternary centers becomes a key here. John, thank you so much for taking the time to cover CLL studies from ASH 2024. For our listeners, let us go over a quick recap. In today's discussion with Dr. John Allan from New York Presbyterian Hospital, we had a chance to focus on a few key studies from ASH 2024. We touched on Sequoia update, which led to the approval of zanubrutinib for CLL in frontline settings as a single agent. Then we had a chance to focus on acalabrutinib with venetoclax and ongoing study for zanubrutinib with another BCL2 inhibitor. Lastly, we discussed the role of CAR T in this space as well.
If combination options with BCL2 inhibitors, with BTK inhibitors were to become available, balancing side effects will become very important. Right now, our options are zanubrutinib or acalabrutinib, or limited time treatment with venetoclax with obinutuzumab in frontline. Thank you for joining us. Make sure to check out our other ASH and SABCS 2024 discussions. We are the Oncology Brothers.